How can we make the world better? By making ourselves better. The Dr. Joe Show explores how you can make positive personal change by using his groundbreaking and highly effective I Am approach to understand who we are and why we do what we do. Your small changes can have big effects.
Join us now for the Dr. Joe Show with Mark Stiles of Stiles Law, Thomas McCoy, and your host, Dr. Joe Schrand.
Welcome to the Dr. Joe Show.
Well, Tom, that was fantastic. Right in there. No pretense, no nothing. Thank you.
Thank you. Thank you.
So if you wouldn't mind introducing our guest for tonight.
Absolutely, Dr. Joe. Tonight, we are welcoming Dr. Alexander Walley. Alexander Walley, MD, is professor of medicine at Boston University Chobanian and Avedisian School of Medicine, primary care physician and addiction specialist at Boston Medical Center, focused on the medical complications of substance use, specifically HIV and overdose. He has developed an inpatient addiction consult service and low-barrier walk-in addiction clinic. Dr. Walley is a founding member of the Graken Addiction Medicine Fellowship and the president-elect of the American College of Academic Addiction Medicine. He serves as the medical director for the Massachusetts Department of Public Health's Bureau of Substance Addiction Services and the Overdose Prevention Program, which has trained and equipped over 100,000 people in Massachusetts communities with naloxone rescue kits, including people at risk for overdose and their social networks. Welcome to the Dr. Joe Show.
Tom, Dr. Joe, thanks so much for having me. I've been looking forward to it.
So have I. It's so great to reconnect with you. Just, full disclosure, folks. Alex Wall and I go back many, many years when Castle was still around, and you were just, we were just dealing with the opioid crisis. And weren't you involved in getting a state prescription for Narcan for anybody could get it? I mean, what was, remember that?
Yeah, I remember that. So naloxone, also called by the brand name Narcan, there's also one called Oxado, is the antidote to an opioid overdose, and it's one of the tools that we have to address the continuingly increasing opioid overdoses. It's really sad how many people we lose every year, but there's more people that are saved every year by their loved ones, by themselves, and by the antidote, naloxone. So Massachusetts has been an early adopter of the public health intervention. It's been distributed through community-based programs, really underground since the late 1990s by harm reduction programs, which really are made up of people who use drugs themselves. But then in 2007, some forward-looking state leaders started to fund naloxone distribution in the community, and I had the fortune of being the medical director and the medical license behind that community distribution. It was expanded to make naloxone available at every pharmacy in Massachusetts since 2017. Really, what was behind the counter. And so anyone can go to any pharmacy in Massachusetts and ask the pharmacist for a naloxone rescue kit. They will first ask you if you want to bill your insurance. And if you do, then you get the kit for your copay. Or if you want to pay out of pocket, you can pay out of pocket. Or you can go to one of the many community programs now that distribute it for free. So thanks for allowing me to plug that, Tom, because it's an important public health intervention that we have in Massachusetts. It's really been other states have followed, basically. So it's a bright spot in a dark landscape of what we're dealing with overdoses, but something I jump at the chance to get the word out. So thank you.
No, absolutely, and it's incredible what you've done. How many lives you have saved, and naloxone. The other part that's interesting, it's the only medicine that I prescribe that I expect to be diverted to somebody else other than who I prescribe it to. Isn't that remarkable?
Yeah, that's right. And I will say, so I'm an addiction treatment provider as you are, and I offer it to my patients who are coming in for treatment. And oftentimes the first response is, well, doc, I'm trying not to use. Why are you giving me this? And so that conversation goes in two directions. So first of all, I say, look, I'm really glad that your plan A is to be abstinent, to not use for opioids again. But I got to tell you that I'm not talking about you specifically, but in general, this is a relapsing, remitting condition. And when I ask you what your plan is, I want you to have a plan if you use again. And so why don't you tell me what your plan is? And so then that opens up the discussion. A lot of times people say, my plan is, well, I'm going to call a friend. That's a great plan, right? But then I say, well, that's a good plan. Plan A is not to use. Plan B is to call somebody. Well, what's your plan C? What are you going to do? What is your plan if you're going to use? And so, you know, hopefully what it is that they're going to have somebody there with them, that person is going to have naloxone and be prepared in the case that they need to use it, and also be able to pick up the phone and call for help. And so that's an important part of the discussion. The other part of the discussion is like, look, actually, I'm giving you this naloxone because, yeah, maybe somebody will be able to help you out with it, but more likely you're going to be able to use it to help somebody else out, which I think is what you were referring to. Like, we actually, this is something we can prescribe to people where they can save other people's lives. And that's extremely empowering for folks. You know, it's really the people who use drugs themselves and their loved ones, their family, their social networks, who have done a lot of the rescue, all the rescuing, really. I mean, along with our first responders, of course, but really the lion's share of the overdoses that have been rescued have really been at the hands of people who, who are in the networks of people who use drugs. So that's how that be.
Is that already, or should it be more of a protocol similar to how, buildings need to have fire extinguishers, or airplanes and passenger vessels need to have a first aid kit? I can see this becoming common practice to have store Narcan ready.
Yeah, well, so it is required in Massachusetts pharmacies for them to stock it and to make it available for people that ask for it. I will say, for those prescribers out there, there's still a role for you to prescribe it. Having your prescriber's endorsement, I think, really makes a difference, but you don't need a prescription. And then probably in the fall, the FDA has approved over-the-counter naloxone. So pretty soon we're going to see where you don't even need to ask the pharmacist. You can just pull it off the shelf. And now the big question there is, how much is it going to cost? And is that going to be doable for people? But police officers in most places in Massachusetts now are carrying it. As there's a whole movement around what they call nalox boxes, which are essentially the same idea as an AED posting, in the community, at places, public spaces. That's not mandated, but there's increasing interest of putting those in places where there are so-called overdose hotspots. That's the general direction that this is moving. It started out really very much as a countercultural harm reduction intervention that people who use drugs came up with themselves. It was embraced eventually by the public health world, by the medical world, and now it's really mainstream. It's central to the national and the state plans to address the overdose, the increasing overdoses that we're seing.
Yeah. Did I hear correctly? Are you about to be the president of ASAM?
ASAM is the American Society of Addiction Medicine, a very important providers group. No, I'm not going to be the president of ASAM. ACAM, which is what you used to know as ABAM. So it's now evolved into ACAM, and that is the American College of Academic Addiction Medicine. And really, we are an organization that is focused. It's a nonprofit, non-commercial organization. We really are focused on promoting and supporting addiction medicine fellowships. So physicians who are interested in specializing in addiction medicine, we are really their voice and support them. And not at the exclusion of other disciplines, by the way. We very much recognize that to address substance use, we need the whole village, but we need to train physicians to really learn how to take care and be leaders in taking care of people who struggle with substance use. So I'm very proud of ACAM. Anybody's interested, they can check it out at acaam.org.
Well, congratulations, and they could not have a better leader. I mean, we've had great leaders in the past, but having you there is inspirational. I'm delighted. We were talking about something called harm reduction. Some people may not really understand what that is. Can you give us a sort of thumbnail of it?
Well, sure. So in the world of substance use, it's actually has historically been a very politicized term. And for a long time in the United States, when it comes to public health and the government and drug policy, it was kind of a dirty word. Like, people who were writing grants, say, for example, if they mentioned harm reduction in the grants, they wouldn't be funded. And it wasn't actually, mentioned in public health policy. That's all changed in the last couple of years, by the way. And harm reduction is actually one of the pillars now of the federal strategy to address substance use. And I think of it as a close companion with treatment. So treatment is for people who are ready for treatment, who are interested in treatment. And we're lucky in substance use, particularly opioids. We have really effective treatments. But all of them hinge sort of on people's engagement and their access, et cetera. There are going to be people who either don't have access to treatment or they're not interested or ready or wanting treatment. And in both of those cases, we need to do as much as we can to help people live their best lives. And that starts with living their lives, right? So naloxone, the antidote to an overdose, is specifically for people who are still using, and the idea is to keep them alive. And that alone, full stop, is enough in my book. I think it's really important and to recognize the inherent value of every individual, regardless of the behaviors that they choose or what they do to cope with the things that they've confronted in their lives or their genetic load. These are things that drive substance use, right? So people who've been hurt oftentimes cope with that pain, whether it's psychological or physical, by medicating themselves. People have a genetic drive for addiction, distributed differently in our society, so it's quite natural and normal for hundreds, thousands of years for people to reach for a substance to make them feel good or to make them feel better. I don't think we should dehumanize people for that. And we have a long history of, frankly, doing that with the war on drugs and the criminalization of people, not just drugs, but of people who use drugs. So harm reduction is very much a set of concrete strategies like naloxone distribution, like syringe service programs, and like low barrier access to healthcare, meaning not mandating abstinence before treating people with the treatments that work and the treatments that they deserve. So those are some of the concrete things we think of when we think about harm reduction. But harm reduction is also an approach to other human beings. To some of the common mantras in harm reduction would be nothing about us without us. So like engaging the people that we're trying to care for in meaningful and empowered dialogue around what they want their care to be like and how we can help them. And another mantra is any positive change, which seems like it might overlap with some of the Dr. Joe approach of small changes, big effects. And so any positive change is definitely a central tenet in harm reduction. And so we want to claim any positive change as a victory and continue to try to support those going forward.
Yeah, it's important because there's been such a stigma about mental health, but certainly substance use. And that's why I wanted to point out earlier, you mentioned that you're working with folks who have this condition. I was so grateful that you used the word condition and not the word disorder. Because as soon as we use the word disorder, we separate people into these groups. This group is okay. Not sure I can trust that other group. We created, without meaning to, but we contributed at least to this isolation and stigmatization.
Yeah. So, I mean, not just a disorder, but a disease, right? And there's what we call the disease model of addiction, which I think is really the primary view or frame that medical students are taught in medical school now. There's a lot of positive aspects, I think, to framing it as a disease or disorder, namely that it makes it science-based, I think. And the goal there, I think, Joe, was to destigmatize it, right? To sort of say that it's not a moral failing, it's a disorder or a disease, right? And really what I learned from you and one of my colleagues, mentees, former fellows, and now peer mentor, Sarah Bagley, who's interested in this young adult, adolescent population, is if we tell somebody who's 21, 22 years old that they have a disorder or they have a chronic disease, that is extremely stigmatizing, right? And it's really hard for them to face. And actually, what substance use or addiction also is a developmental condition or a developmental disorder. It clusters in certain age groups at certain times when the brain is changing. And those ages are in the adolescent through the young adult years. That's when people are more naturally at risk because that's part of their brain development. So it's a developmental condition, or you could call it a disorder. But when you call it a developmental disorder, most people grow out of it, actually. That's the developmental part. There's also a learning piece to it. Like people don't learn the same thing. There's a problem with their learning where there's negative consequences by definition to somebody who has an addiction. They're not learning from their negative consequences. They're continuing to use in a compulsive way despite their negative consequences. So there's a problem, we would say, in their learning. There's this fourth way I've been thinking about it. So all those ways I think are not perfect, but in my view, they're helpful, but it depends on the audience and we need to qualify them because, as you said, with the disorder disease, it can be very off-putting and stigmatizing people, which is actually can drive more substance use. Right. And so that can be problematic. It being just a learning disorder, I think, it's not that simple. And then this issue about being it developmental. Well, yes, it is developmental, but it's not just developmental. This fourth thing I heard from Maya Salovitz, who's a writer, who's a person with lived experience, published some books, one called Undoing Drugs. And she described it as this issue where people can love a substance like they would love a person. And so it's a misplacing of love. And that hinges on this definition of love, where love, to really love somebody is, yes, to care for them, to honor them, to respect them, but also to do things for them that you wouldn't otherwise do. And I can think of examples in my own marriage, which is really kind of where where I do things for my wife that I would not do for myself or for other people. And I know she does the same thing for me. But then if I were to do that for a drug, right, like I would do things that I wouldn't otherwise do that are actually maybe harmful to me, that sort of. And so, you often talk about oxytocin and the role of that, right? And, I think it's sort of underappreciated. So anyway, I wanted to pose that to you just to see if you maybe have been down this road and thought it through and have it all figured out. But that's one of the things I've been thinking about recently.
Yeah, it is absolutely part of it, because the way we sort of understand drugs and alcohol is they force the release of this ancient chemical called dopamine. And again, this is really sort of simplifying the model, but dopamine really is a very selfish chemical. It's an important chemical in our body. It's used for all sorts of things, but it's selfish. It's really about dopamine. So when we experience this dopamine pleasure, we get this positive reinforcement. The way I like to say it, Tom's heard it so many times, but does the name Pavlov ring a bell? Right. So it's the Pavlovian positive behavioral reinforcement. You get this rush from dopamine, and your brain remembers that in the limbic system, the ancient limbic system. But we know that dopamine interferes with another neurohormone, oxytocin, not OxyContin, oxytocin, which is the neurohormone of trust. It interferes with it. So one of the things that we teach is you can get high, but the price you pay is trust. You just decide which pleasure is more important to you. So yes, I think that there are folks who absolutely love this dopamine rush, but on some level, they are realizing the price they pay for it are all the people around them, all the people who now don't trust them, which then unfortunately makes them feel less valuable with less pleasure. And dopamine says, what are you waiting for? I know what you can do.
It's one area that we're still so comfortable stigmatizing people. Because there's plenty of conditions and diseases that can be the result of lifestyle choices that we don't berate people over, like lung cancer. Friends and family will smoke and they'll get lung cancer. We see it coming, but we don't treat them as less than once they get lung cancer. We don't abandon them. Right. Obesity. There are plenty of problems that come with that, but we don't treat people. We're not supposed to. I mean, it's rude to treat people as less than for any health problems, but for some reason, when it comes to addiction, it's cut them loose. They're not worth it.
And Alex, I have a theory about that, but what's your take on that? Tom is right. I mean, we absolutely turn our back on the people who need us the most.
Yeah, and everyone is really touched. So it really hits all segments and sectors of society. I will say, like a lot of health conditions, there is a disproportionate impact on people who are outside the mainstream. Whether it's because of poverty or because of racism or because of other discrimination. So, I've had the opportunity this year. I've been on a sabbatical where I haven't been seeing patients for the year. Been continuing some of the research, which we'll talk about, but I've been able to visit other places where they don't have the same history of stigmatizing substance use or substance use treatment, for that matter. And that is a first step. So, and really, it's one way it's manifested is by criminalization. So there's no higher form of stigma than criminalizing something, right? That is state-sanctioned stigmatization. And there are countries that don't criminalize drug use. They criminalize other crimes like property crimes, and right. So it doesn't mean there's a free-for-all in the society, but when you use a substance, you're hurting yourself more than you're hurting anybody else. Now, it does tear families apart. It can, particularly the addiction, the behaviors that follow, but the actual using of the substance doesn't actually hurt anyone, except if you're drunk driving, and that's a crime, right? If you drive and you kill somebody, then I think largely that's accepted as a crime. So, but even in the other countries that I've been to, which include Portugal and Uruguay and Scotland, where they have more progressive drug policies, there still is an outcast group in society. And those people who are outcasts, who are marginalized, who are discriminated against for other reasons, they often are going to seek solace and respite in using substances. And so, and then the stigmatization, right there, that's part of my response, is that stigmatizing people for other reasons can feed into substance use. And a lot of it gets to sort of how their people are externally and internally valued, right? And the using a substance, they're trying to alter their consciousness, right? Because they don't like the way they feel, or the substances really make them feel good, at least in the beginning. So anyway, I don't have a simple cure for stigma. I know that a good place to start is decriminalization, and not punching down. That's essentially what we do when we criminalize drugs, is we're trying to hurt people who are already hurting. And we know better. We have better things to offer people, right?
Well, that's what the war on drugs was all about from the beginning.
Absolutely. And it's worth it. Like the time it takes to spend to show people respect and support and dignity, and provide them with evidence-based treatments that we know that work, that pays off. Anyway, I could go on and on about how we, don't make the things we know work readily available to people, which is another thing that is very clear as I've looked at other countries. And a lot of the treatments that we have that are effective actually were developed in the United States, but we don't make them accessible on a population level the way they do in other countries that are poorer and have less resources than we do. So that's also the truth in a lot of healthcare. That's not unique to substance use, but it's still the same story there.
And so important to identify so that we can do something about it. So tell us a bit about the research you've been doing.
My research is really focused on overdose prevention, and I talked already about naloxone, and we've studied the impacts of distributing naloxone in the community, and so done a number of projects to show kind of how it works, how do you communicate with people around overdose, and what the community level impact is. And so we've done some quasi-experimental design studies that really show a reduction in overdose death when you distribute naloxone at the community level. The more recent line of research that I've really been focusing on is what's called post-overdose outreach. So the biggest risk factor for an overdose, a fatal overdose, is a previous non-fatal overdose. This is very analogous to depression, right? Suicide. So when somebody attempts suicide, that actually, there's this conventional wisdom that if somebody has attempted suicide multiple times, that maybe, there's somebody shouldn't be as worried about, right? Because it's crying wolf. But in reality, those are the very people who end up actually completing a suicide attempt or dying by suicide. And so we need to bring that same lens. And so when somebody has had a suicide attempt, we need to muster resources towards them and really support them in getting treatment and really getting connected, really, like to have their depression addressed. Well, I think the same is true for somebody who's had a non-fatal overdose. And so I'm very interested in the relationship between non-fatal overdose and fatal overdose, because if somebody on their own raises their hand and says, I want treatment, they now declared themselves, they're identified, right? The person who goes to a harm reduction agency, they've said I care enough about myself that if I'm going to use, I want to use more safely, right? But the non-fatal overdose, that's usually not somebody raising their hand and saying, I need help or I want help. It's someone else has called for help, right? And they've been taken to the emergency department. And oftentimes when they get taken to the emergency department, they have a difficult experience there. They're released from the emergency department and they're not interested in treatment. And in fact, they oftentimes are released in withdrawal. So there's efforts to make treatment available at the emergency department, but still the mindset oftentimes right after you've been rescued from an overdose isn't to jump right into treatment, right? It's really to get away from the health system. And so this question of how do we engage this population of people who isn't asking for help, who may not be engaging in harm reduction, but is identified by having a non-fatal overdose, is a very tricky relationship and engagement problem. They're a high risk from a public health perspective, but we don't know exactly how to engage them. Well, organically in Massachusetts, community by community over the last 5 years, many municipalities have forged these public health, public safety partnerships that are doing proactive outreach to these folks. And this is not evidence-based. It's really driven by what else can we do? What else can we do about this? It's really trying to respond to the crisis. And it's a valiant effort. And actually, we just published a study in JAMA Psychiatry in March 15th, which showed that the implementation of these programs is associated with a small but a significant reduction in overdose deaths. So that's good news. It's not a randomized controlled trial. It's a quasi-experimental design, but it's promising evidence that these actually may be effective. But how they're implemented varies widely from community to community, okay? And one of the key issues that we think a lot about is what is the approach how do you approach people, and what do you approach them with? And some of the programs initially start off with, like, we just need to come to people's homes and offer them treatment. And I think personally, and we have some evidence to start shows that you need a much more nuanced view. You need to really meet people where they are at, which is a key harm reduction term, but also an important, I think, wise counseling term. We need to meet people at where they're at and offer them what they need at the time, their concrete needs, and include both harm reduction and treatment resources. So anyway, I could go on and on, but that's one of the research areas that I'm really interested in. And it's a difficult problem. It's not as simple as just making naloxone available as widely as possible. That, to me, that's much more simple. But although there's complications there, but this is really because when you go and knock on somebody's door, you could be turning them off. In some neighborhoods, maybe more than others, depending on who is knocking on that door. It gets into issues around cultural responsiveness. Turns out half the time when these outreaches occur, they're reaching the family with or without the overdose survivor. So how do you deal with the family, or how do you support the family? Because a lot of times these families either maybe they don't know what's happened, or they're they're in a lot of pain, and so we need to offer them support when we engage with them.
Yeah, it's such a dilemma to knock on someone's door. All we're offering is help, and yet I think we get sort of lumped in with the stigma that somehow we are going to be the ones judging these people as less than and broken. And that's absolutely, I mean, I know you and certainly people know that is not my approach at all. We're just trying to remind people of their value. I think a lot of people have felt dismissed with no happiness, and that's where dopamine comes in. That's where it's got its allure.
I'll just tell you, though, that there are people who are very skilled at this, and I think these skills can be taught, about how to really engage people on their own terms, to meet them where they're at without judgment, just love, no judgment,
respect, with respect.
Shame. Yes, with respect. And doing that in the community is different. It's a different, it's some of the same principles, but it's a different skill than the approach I try to use in my office, right? The skills are sort of the same idea. Like I try to really listen and understand where the person's coming from, what they're looking for, how I can meet them where they're at. I have an agenda, and I try to make that explicit, but really secondary to the person I'm trying to help, right? Because and almost always the agendas are going to overlap in some areas, and that's where you start. That's but that's in a healthcare setting, which is designed for a particular purpose. When we're trying to go engage people in their communities on their own terms, it's a different approach, which takes special skills.
It can, but it is about respect and value and meeting people where they're at. And we were talking off air a little bit about whether there was an increase in fatal and lethal overdoses during COVID. And Alex, you had some thoughts about that.
Sure. So I think, like a lot of health issues, there was a reduction in access to treatment and to some degree harm reduction services. Although I have to say I am extremely proud of the workforce in Massachusetts, both the treatment and the harm reduction workforce. They were considered essential workers and essential services, which was not true in other states necessarily. And they stayed out there, and they put their own lives at risk to continue the services. However, they had to do it under different terms. So even there have been a number of residential treatment programs that have closed down, while access to medications like buprenorphine and methadone have expanded. But you had to de-densify the residential units, which just meant there were less treatment slots. And then, we don't pay people enough in order to staff these programs. And this is true throughout a lot of healthcare. And we still have an ongoing workforce shortage. So if anybody's looking for a rewarding, soul-filling career, I encourage you to really think about getting into helping people with substance use. It's as bad as it is. Every day I get to hear somebody who has made substantial progress, small changes with big effects in their lives. Yeah. And to bear witness to that, to have any role in that is just really, really rewarding work. The other part I need to mention during COVID is the racial inequities and ethnic inequities that were felt certainly in Massachusetts. So there were surges in overdose deaths among Black people in Massachusetts, Latinx, Latino, Hispanic people, and our Native population or our indigenous population, which oftentimes hasn't gotten the attention it really deserves in when we think about substance use. And so it's a really those are important areas, and we need to really focus our resources and our care on those populations so that they can get the care that they deserve.
Yeah. And for those of you who are listening who may be in recovery yourself, who have gone through this, your lived experience is invaluable and can help so many. One of my phrases, contribute to society to help with your sobriety. I mean, because when you are helping others, you're increasing not only their value, but yours. And that can really, that can increase oxytocin. We know that oxytocin now can break the loop of addiction. We've known that since 2011. Great paper came out, and we can still do it. We can still do it. And we have to. This, COVID was not an immunization against substance use.
It certainly wasn't. We need people, so.
Yeah. How did you get into this work, Alex?
Well, I didn't have any physicians in my family. I thought I went, but I have two sons in college now, and I am remembering. So I'm thinking about what my mindset was when I was in college, trying to think about what I wanted to do. I didn't actually do any science courses in college. I had a literature teacher who was a physician, actually a child psychiatrist, Robert Coles, and he talked about his medical training and his experience as a psychiatrist and during difficult times during the 60s. And that inspired me to think about going into medicine. So that sort of got me curious about it. And then I was in medical school in the mid 90s in Baltimore, where the HIV, my first year of medical school, there was a treatment for the first time for HIV that actually could keep it from being a terminal illness to making it a chronic disease. And so that was transformative. But then I spent the next 4 years taking care of people in the hospital who were still dying from HIV. And most of them were using substances, and they did not get access because of stigma and other reasons. And so the tremendous progress we made on HIV has really been an inspiration for me in thinking about how we can care for people who use substances. It's not just about the medicines. The medicines are very important, but it's not just about the medicines. It's about creating a system of care that really is accessible and centers their experience and addresses their other issues, that come along with the condition. So that's what got me started.
Yeah, it's true. I mean, we call it medication-assisted treatment. the medication is to assist. It is not the centerpiece of the treatment. It is the community. It is the people around the person. Medication is important, but it's just a small change in the biological domain.
I will say that I do have one concern. I'm a little bit of a wordsmith about medication-assisted treatment. It's not my favorite phrase because it can be used to make a medication last argument, which is that you don't deserve medication until you're willing to do counseling. And that is literally a fatal error that we have made in our profession. And we now need to offer people whatever works whenever they're ready. And so that can mean medication first. And that doesn't mean there's no value to counseling. Of course, there's value to counseling, but there's some people who just can't sit and talk, then they need to have their withdrawal treated first, you know? And so anyway, I don't want to get too much into the terms, but that's, medication alone is very helpful to some people. It's probably not the answer long-term. It's a good place to start. And with a lot of substances, we don't have any medication, right? So we need to rely on other things which work. I mean, counseling works also, right? But people have to sit for it.
No, I agree. I mean, I'm not saying that we withhold medicine until you're ready to do that, but I want people to know that it's more than just medication. There's a whole bunch of things that we'll go into because you're not alone in this. We got in mind the IM approach, just to come back to it. We're all doing the best we can, influenced by these four domains of your home, your social domain, the biological domain, and the IC, the way I see myself, the way other people see me. Because these domains interact, a small change can have a big effect. When we add a medicine, we're making a small change in a biological domain. Alex, based on what we're talking about tonight, what small change can you recommend to our listeners?
It's going to be a language thing, which maybe you have already covered, but something called person-first language, which doesn't only apply to addiction, but I think it's one of the places where we can really apply it. And the clearest example is the term addict, right? So I don't use that term. I don't judge people who describe themselves that way. That's for them to describe themselves. But as I don't describe other people that way. I describe them as people first. So people who use substances or people who inject drugs or a person who has HIV infection, a person with diabetes, or a person with schizophrenia. So I also don't use the term diabetic or schizophrenic, right? It's person first language. And that's a small change that I don't know if you ever had John Kelly on the show, but he's from Mass General, from the Recovery Research Institute. We have
had him on the show. Yes, okay. We have had John.
He's already talked about that, but that terminology makes a big difference in how we treat people, actually physically treat people. So that's a small change that can have a big effect.
I think that's a powerful one. Very important. Words really do matter, folks. Words matter. The second truth about the IM, everyone has one. And everyone is interested in what you think or feel about them through their IC domain, which has an effect on their biological domain, because it feels different when you feel respected or disrespected. So what this means is you control no one, but you influence everyone. You get to choose the kind of influence you want to be. Dr. Alexander Walley, what kind of influence do you want to be?
Well, so I like to set an example. I like to be honest with myself, and so try to be honest with other people about what I don't know, which is a lot. And so, but I think talking and acknowledging what we don't know is really, really important influence on others. And so when I have seen people who I respect talk about what they don't know, I get curious, I get interested, and I think it's opening a door to a discussion, curiosity, and discovery.
Yeah. And we need that because we have for so long just sort of locked people into one position. You're an addict, And one of the early phrases I had when I was doing drugs-free theater and Castle was, you can hate the addiction, but not the person. I mean, it's not just who they are. And this has been an incredible discussion. Alex, thank you so much for being on the show. If people want to read your work or know where you're at, I mean, I know you're on sabbatical, but how do people find the work that Alex Walley does?
Wow. I don't know, Joe. You can certainly find me. I don't have my own personal webpage, but you can certainly search me, Boston University, and you'll get a whole page on my clinical work and my research and all the things that we've published and are working on. So,
thank you so much for all the people and for all the lives you've saved. Appreciate it, Alex. Thank you.
Thank you, Joe.
We'll see you all next week.
Bye,
Bye, folks.
Bye-bye.